BPH and prostate cancer.
Bless your lungs.
So, safe and effective care environment for management of care. You want to provide client education on the disease and educate on screening, collaborate with other team members as necessary, like urology, their primary care provider, maintain patient privacy and dignity because it's urination, so you want to make sure you're providing privacy. Recognize limitations to patients regarding the diagnosis. Verify the client receives education and consents for care and procedures. So there's surgeries that can help fix BPH or prostate cancer, so they want to have the informed consents for that. And assess the need for referrals. Assess the client's care environment, make sure it's safe, make sure they have a clear path to the bathroom. Properly identify the client when you're providing care. You want them to drink at least 3,000 milliliters of fluid unless it's limited due to cardiac issues to help flush out and prevent a UTI. They should try to avoid every 2 to 4 hours because BPH can cause urinary retention. And so you want them to go to the bathroom, make sure they're not holding anything in. So yeah, urinary retention is very common with BPH, and this can cause an increased risk of UTI and eventually cause kidney damage if not properly treated. You want to note change in behavior because UTIs can cause sudden confusion in older adults. And then I did apply principles of infection prevention for the prostatectomy. You want to maintain the sterile catheter system, ambulate with the drainage bag dependent to prevent backward reflux of urine, change dressings frequently and as ordered, use antibiotics as indicated, and do bladder irrigation. And then obviously make sure they're washing their hands, that you're wearing gloves, stuff like that when handling body fluids. So BPH is benign prostate hyperplasia. It's the abnormal cell growth causing the prostate to become enlarged, and that blocks the flow of urine. It's not linked to prostate cancer and does not increase the risk, but it does have very similar symptoms. So prostate cancer can cause trouble urinating, decrease of urine stream, blood in urine, blood in semen, bone pain, and erectile dysfunction. So if a client is noticing any of those, they want to make sure they're telling the provider, especially if they're not going to the bathroom for an extended period of time. And then BPH is increased frequency of urination at night, trouble starting a stream, a weak urine stream, urinary retention, and less common is blood in urine, inability to urinate, UTIs, and bladder calculi, which is bladder stones. So you want to assess and manage client with an alteration in bowel and bladder elimination. So making sure that they are able to go to the bathroom, have everything they need, like a urinal or assistive devices to get to the bathroom. Non-pharmacological comfort measures, which I had as like a sitz bath to help relax muscles. Acute pain can occur with irritation of the mucosa because they often need repeated catheterization from the urinary retention. Also can cause pain from the urinary tract infections, bladder stones, and radiation that is used to treat prostate cancer. You want to administer medications as indicated, such as antispasmodics and bladder sedatives, such as oxybutynin and pain medication. And then catheterization can help relieve discomfort by reducing bladder tension if they're holding in all their urine. So prostate cancer screening, at age 50, men are at average risk and are expected to live at least 10 or more years, should get a screen. Age 45 for men at higher risk. This includes African Americans and men who have a first degree relative diagnosed with prostate cancer. And then age 40 for men at a higher risk who have more than one first degree relative. So that'd be like an uncle or a brother or a parent. And then the prostate-specific antigen test and digital rectal exams are part of the screening. The digital rectal exam allows a provider to feel for any lumps on the prostate or if it is enlarged for BPH. So if the screening, such as digital rectal exam or the PSA test, shows no indication of prostate cancer, the time between screenings that is recommended is different. So a PSA that's less than 2.5 may only need retesting done every 2 years, but if it's greater than 2.5, they should have it every single year. And then imaging may better allow visualization of the prostate, such as a transrectal ultrasound or an MRI to show enlarged or abnormal growths of the prostate. So for this one, you'd want to evaluate clients' response to medication, dispose of medication safely, because it is prostate cancer and chemotherapy medications can be used. You'd want to make sure you're wearing appropriate gloves and personal protective equipment. And then for BPH, alpha blockers are used. So most of you have probably heard of Flomax or tamsulosin. That helps relax the smooth muscle and allow urination. And then other alpha blockers are doxazosin or Cardura and alfuzosin. And then 5-alpha reductase inhibitors help to shrink the prostate. Those are finasteride and dutasteride. And then tadalafil or Cialis is typically used for erectile dysfunction, but can also help treat an enlarged prostate. So the most common surgical intervention for BPH is a TURP, which it removes the obstructive prostate tissue surrounding the urethra so that urine can flow freely. And then there's a TUIP, transurethral incision of the prostate, and then transurethral microwave thermotherapy that allows microwave energy to shrink the prostate, and then an orchiectomy that removes the testes, and this is irreversible, so they'd want to know that this would prevent them from having children, and it causes a decrease in androgen and testosterone production, which causes the prostate cancer to shrink or stop growing. So a large prostate rarely occurs before the age of 40, so it's necessary to get screening as men get older, and prostate cancer usually occurs after age 50. Comorbidities such as diabetes and heart disease may increase the risk, as well as obesity. So risk reduction would include eating a healthy diet, exercise, and maintaining a healthy weight. And then you'd also want to monitor the results of diagnostic tests such as the PSA and stuff like that, and intervene as needed for the patient. Patients with BPH may experience fear and anxiety related to surgery that may be needed to treat the condition. So you'll want to educate them regarding their condition. They also might experience embarrassment about it and concerns about sexual ability, which may occur due to medications or surgery. You want to provide reassurance that permanent sexual dysfunction is rare with surgery, but it is something that can happen. Provide privacy and dignity to patients, specifically with exposure genitals. Reduce stress by practicing relaxation techniques or meditation, as stress can cause increased urinary frequency. And then Kegel exercise education for BPH to help strengthen the bladder tone to limit any dribbling or leaking of urine and help with urgency. So you want to assess the client support system to aid in the plan of care. A prostatectomy can cause sexual dysfunction due to removal of the prostate gland, which plays a role in the production of seminal fluid. This can cause decrease in libido, erectile dysfunction, and other sexual issues such as male infertility. So you'll want to discuss changes in body image that they may feel and sexual functioning with patient and their significant other. And then medications such as finasteride can inhibit sexual function by decreasing libido and erection, so you want to discuss side effects. Alternatives such as Flomax or Cardura do not decrease testosterone and may be preferred. So I have some questions.
do you think, guys?
Is this one D?
Yeah, I'd say.
Okay.
I think D is wrong because it doesn't necessarily cause sterility. It can, but it's not like guaranteed.
Do you see the difference in the wording? Erectile problems are rare, so it could happen, but rare. D, it won't be a problem. And we can't ever portray that because we have no idea, right?
Oh, absolutely will not be a problem.
You think B?
No, that's that girl in that
I worked
surgical
with
video.
one
I
I know, it's
man
like-
who had one, it was a pain in the butt.
don't wanna hear about that.
Kimberly.
I don't know if anybody even heard me. It was a bad joke. It was a bad joke. It had a bowl, we had to pump it, or so I was told. I was 20, I was still pretty naive, back in the day. What do you think?
Anyone?
Anyone?
Hang on, yeah. I'm a really slow reader, give me a second.
Just because she never talked about metastatic, right, so I think that's out.
T?
So PSA can be elevated by other things. I think it said like they recently like ejaculated or something like that. There's tons of other things that can cause that to go up, but typically if it's elevated, it's an issue with the prostate.
I got my answers.
A, maybe B, and then D and E.
Why is it not C?
It's the meds that do that, right?
Yeah, and it says differential diagnosis, so like problems in the intimacy could be from so many other things, like being nervous and stuff like that. That's all I have.
Good questions. I think next week we'll, yes, thank you, Jessica. I think next week we'll try and come back to this. I wanna make sure you understand a TERP.